Morning, everyone. We'll start this public briefing. Thanks for coming along. And just a brief word of introduction from me. As usual, I'll try and update you on what's going on out there in NHS world. It's, as ever, very complicated at the moment. The big thing is that there is a merger at the top of the two regulators who we look after or look after us. So there's NHSI, who is our official regulator, and then there's NHSE, who look after the CCGs and the GPs and primary care, and basically run by Simon Stevens and set the NHS policy. So these organisations are coming together at the top. For us, it means that there will be a merger of NHSI and NHSE at London level, which effectively means the bringing together of, if you like, the primary care CCG arm and the provider arm, the trust arm. London will be divided under this new system. London will be divided into two. There will be a North London and a South London, and then it'll be subdivided. And you will not be surprised to know that there will be a South West London combined NHS organisation. So for those of you with long memories like me, if you remember the old South West Thames Regional Health Authority, it's something similar, not the same, but something similar in a way to that from 25 years ago. So as is always the case in these things, what goes round comes round, and it's being put together as we speak. They haven't actually formally announced who is going to be the head of NHS London, but we all sort of think we know, but that will be announced very, very soon. How the detail will then cascade down as to, will there be a head of South London, will there be a head of South West London, we're very unsure. But clearly on a day-to-day basis, a week-to-week basis, it means that the relationships that we built up over the years with various people at NHSI will change, because the people will change. And so it's going to be a time of some change, and change is always a challenge, but I'm sure we will get through it. So this new organizational structure will start at a date not yet quite announced, but probably within the next month, but let's say for the sake of argument on the 1st of January. So that's the big news as far as we're concerned for out there. Obviously there are other issues which will be concerning everybody. Brexit and the Health Secretary's alleged comment that people will be at risk, stockpiling drugs. We can talk a little bit more about that. I think that, none of us know what's going to happen, do we really? So we just have to take it on a day-by-day, week-by-week basis. There is certainly going to be some degree of Brexit impact if it happens as a no deal, and both NHSI, NHSE, and the trust itself are making preparations for such an event. Anyway, that's all from me. So, Daniel, do you want to just summarise the main thing?
No, because it's the performance report.
No, I know that, but I always like you to summarise the main strategic things first, so that people
I haven't thought about that yet.
Well, go think about it. I'm sure you can do this.
Main strategic things from me. So we're getting very into how do we do the planning for the year 1920. And I think we're moving really quite fast in both the Sutton Health System and the Surrey Downs one to bring together all of the providers and the CCG into something which says, how would we best use the money that we're allocated in our place to provide the best healthcare, and to get out of the current they're a commissioner and we're a provider and the market dynamic that entails. So we're having some really good conversations in both the systems, and it's interesting watching the change in dynamics of the finance director of Sutton CCG and our finance director talk about, rather than here's the CCG SIP plan and equip plan and here's our SIP plan. So it's actually, what is the joint plan that we can have to use the money better? So that feels like quite a seismic change that is going on in both parts of our the two big communities that we serve. We're doing a lot of planning on the transition for taking on the community services in Sutton from April. And I think we're getting much closer to resolving all the issues about taking on the community services in Surrey Downs. So all the partners have now re-signed a heads of terms to do that. I think everyone in the audience will know that the process to secure our long-term future, improving healthcare together, has taken some steps forward this week with the third of the 3 workshops on the non-financial criteria for choosing between the 3 sites. And there was a scoring workshop, and I wasn't at it. I had reports back from it that it was a very intensive, thought-provoking, very long session that did come to some initial thoughts that get fed into the CCG's decision-making process. And I think I'm then out of strategic updates.
Right. In that case, let's jump through the performance report.
Thank you. So just to start, as we always do, looking at the mortality indicators, the position for the Trust remains strong and positive. You will know that over the course of the last year, we have been seeking to make sure that we review the care we give to patients when they die. And the number of patients whose deaths are subject to review are tabulated at the bottom of page 1.1. This is a very important thing for us to do. There's a huge amount of learning to get from review in this scenario. And I'm really pleased to say that yesterday we began to appoint consultants to actually formally take on the role of reviewing more patients' care so that we can enhance in the future the care that we're providing to patients who come into Epsom and St Helier. So that's a positive intervention. I think that it is worth emphasising that the stroke metrics, which have been challenging to maintain this year, have improved in the month of August, and we have seen more patients spend the requisite amount of time in the stroke unit, and are actually seeing, although it's very small numbers, we're seeing TIA patients within a shorter time frame. This is still subject to ongoing work and collaboration with CCG colleagues, because clearly in terms of seeing the patients in a timely way, we need to make sure we're getting the referrals in from the GP in a timely way. And to that end, the new electronic referral system is actually helping us tremendously in signpost patients to the right clinic. We are working with nursing colleagues to refresh the strategy for assessing patients for both VTE and dementia, because both of these indicators remain significantly below where they should be, and are proposing a new screening system for patients with for VTE, which will allow us, I think, to pick up our surgical patients and to do their assessment in the preoperative clinic rather than on the day of surgery, which I think is a very sensible intervention, and Arlene and the nursing teams who run the clinics are very keen to implement that. So we will be able to update on when that's going to change, and therefore when we expect the metrics to improve, I hope by next month's board. And similarly, we are looking at how we screen our patients for dementia, because again, historically, this has been something that is a medical responsibility, and actually we feel that working collaboratively with nursing and medicine jointly, seeking to make sure patients are screened, will lead to an improved position, and Arlene is leading some work on that. So I think at this stage I'll hand over to Arlene to talk through safe staffing.
Thank you. So 1.2, we are required to report on our care hours per patient day, which is the number of nursing hours we have had over 24 hours, over the number of patients in the bed. We continue to report good numbers against the national average. However, we are in the process of reviewing how our data is collected to ensure that we are reporting as closely or correctly against the national standards. So that's in the process of happening. We are also in the process of reviewing the nursing establishments, looking at whether we do have enough in the budgets going forward as part of the business planning process for next year. One of the things that we do look at is whether our ward managers are able to be supervisory, because we know that if we have supervisory staff on the ward, they're able to troubleshoot and support junior nurses with decision making and support patients and families. However, we're not always been able to achieve that due to just staff available. However, we are introducing something called a clinical matron role, which is designed to be a senior nurse that will work clinically most of the time, as well to support the junior staff. So that would give us an extra layer of quite senior nursing support, working with the consultants to support patients and to support nurses. We have started a recruitment drive to increase the number of healthcare assistants in the organization with the aim of recruiting 100 by December. So that's well on the way. We've interviewed well over 75 and offered, and they're starting to come into post now. That does not replace our registered nurses. It just gives us more hands available to look after patients. And so we're in the process of doing that currently. 1.3 healthcare associated infections. We continue to do really well on MRSA bacteremias, and we didn't have any recorded in September. Our C. diff, we are in September just slightly over where we need to be, and there is work going on around improving or reclaiming that position where we need to be. We also are looking at our hand hygiene training and compliance, which the lead nurse for infection control has updated the hand hygiene data tool, because that was one of the things that we've recognized that is keeping us back. It was so complex, it was difficult to get it right. So we've updated that, and we will be implementing that, which I'm sure will help us to improve the training and compliance and actual delivery of hand hygiene. Maternity care, the two areas that we need to draw to attention, cesarean. So we're doing really well on one-to-one care by midwives. Our cesarean section totals is above where we would like to be. However, as we've said, there's a known correlation between induction and increased rates of intervention, so cesarean sections, but we have to ensure that the babies are as fit as can be and have good outcomes. So we will continue to monitor that, but the priority is ensuring that the babies have the best outcome. In September, we had a decrease in the use of the birth center, and that was largely because we had planned work on the lifts, which we knew was going to happen anyway, and because we're not able to use the lifts, we couldn't use the birth center for some time. That's it really for me.
So there's very little new things to say in the patient experience domain. Our friends and family response is pretty consistent, and our ability to answer complaints is pretty consistently good as well. That's it.
Moving on to operational, sort of responsive domain, which is slide 2.3. Which is slide 2.3. I don't normally need a microphone. The most important news is that we met the 62-day cancer standard in August, and you'll remember that we always report cancer a month in arrears. I'm most pleased with, if you look at the skin and urology breakdown on the right-hand side, We've had a huge number of referrals over the summer and a high number of treatments, and yet we've managed to increase the ability to see and treat patients inside the standards. That's really good news. And the graph on the top right about demand continues its trend about increasing cancer 2-week waits over what we experienced last year. And we're managing that. The graph to the left of it on first waits shows that we're still consistently hitting our ability to see patients within the first 14 days and make sure they see somebody after being referred from a GP. So I think across the cancer domain, the news remains good and we're making progress on most fronts. On elective care, which is primarily about the 18-week pathway, our performance has declined very slightly, and that's largely due to a function of maths. The two things we've been asked to do by NHSI are to reduce our overall PTL, or hold it level, compared to the beginning of this financial year, and do the same with the backlog. So we have managed to reduce our overall waiting list size, but our backlog increased by about 20. So whilst we're doing the right thing by the patients in the round, that gives you a slight decrease in performance. The early indicators for October are that our backlog has dropped by some 250, and it may be slightly more, but we'll be able to round that out in the next week. First outpatient waiting time, we're managing to continue to reduce that, and I think the reason it's higher than it was last year is that we're having to balance some of our capacity that we would have used for first outpatients against the need to manage extra cancer referrals, and that's a delicate balance between those two standards, but we are still managing to reduce that. On diagnostics, we said that we would struggle in September, but we have almost achieved the standard, and again, it was down to ultrasound, particularly musculoskeletal ultrasounds, and we have already confirmed that in October we've achieved the standard, which is what we undertook to achieve. Last minute cancelled operations, we have only had one person who we were unable to rebook for our reasons. So again, the progress we're making on theatres and the way we manage those and the patients through them is bearing fruit. And whilst the average figure for electronic referrals that Ruth alluded to earlier shows 92.2 for September, on the last day of September we were achieving 99 point something, and the CCGs have agreed that we have now, to all intents and purposes, hit every referral being accepted electronically, with some exceptions which they have agreed with us. So we are the best performer in London, and we've done that in about 4 months. That's really good news on elective care. In terms of urgent care, September was a very difficult month. We narrowly failed to achieve the standard, but we retained our position in comparison to our peers, who were second in London and 18th nationally for type 1 performance, so our ability to see our sickest patients. We saw that in September, and that continued into October, and some of that is about our ability to manage peaks in pressure. And if you've been down in the emergency department recently, you'll see there's been some fairly extensive building work to enhance the size of our majors area and increase our ability to offload ambulances, which is really good news. Our management of long, 7 days or longer, and longest, 21 days, continues apace, and those numbers are now starting to come down to the extent that there were some 30 beds available in the hospital at 8 o'clock this morning that we could use. So we've really made inroads into our capacity. Detox are coming down, and our ambulance arrivals, we've agreed with both London Ambulance Service and South East Coast Ambulance that we have done all the things possible until our building programmes complete in the next 2 to 3 weeks, and then we are collectively assured that we think we're going to be able to make some improvements there as well. But again, when you compare what we were to this time last year, I think we've made some real inroads into our ambulance delays as well. I think that's probably me.
Shall I talk through workforce? I think we're... So I think just to pick up some key metrics in the workforce data set, you'll see that vacancy rate came down in month, and I think importantly is actually 2.2% lower than it was this time last year, which is a very positive interjection, and is actually reinforced by the clinical workforce slide, which shows the increasing number of clinicians that we have working in our organisation, which is very positive. That change is underpinned by a huge amount of work that's going in both to develop, create and recruit to medical posts using some kind of innovative job descriptions, innovative ways of working, and I know from the nursing perspective lots of effort and focus on how we recruit both qualified nursing staff and also enhance our HCA recruitment, which is actually going very positively. So it's an area of huge focus, and I think important to highlight in a positive perspective. Sickness absence remains a challenge, although there was a decrease from August. And you'll see here that musculoskeletal issues, not back issues actually now, but other musculoskeletal has become a feature, or the most common reason for staff being on sick. And we've started to see the beginning of flu-like symptoms. We've obviously had an early start to the viral season this year. And I think those are the key points that I was going to highlight. Comms.
So comms is as normal, and then money. We are still on track at the end of September with our achieving the level of deficit that we expected. And those of you who are eagle-eyed, if you go to 3.3, the middle thing on cash, you'll see we have a lot of cash in the month of September, and that's because the money for paying for the new boilers and all the energy improvements has arrived. So now we need to spend it, which Trevor is eagerly getting into gear to do. So as the scaffolding comes down on B and C block, the next massive project to sort out some Helier begins. There you go.
Good. Thank you. Well, let's get on to well-led resources and the risk register. The back.
So the changes to the risk register, then?
Yeah.
We agreed to reduce the risk of medical staffing issues because
We agreed to reduce the risk on medical staffing because of the improvement we've made in being able to recruit doctors for medicine. We have increased the risk relating to interventional radiology because we thought we had got it sussed with St George's, but then it becomes clear that it was an issue for Croydon and Kingston as well, so we have to solve it across all of South West London. We're going to review the risk register further for escalation and out of hours, and we now have the new IT system for maternity, so we can review the risk that related to that. And there's more work we think that we now need to do on adult safeguarding, adult mental health, and children safeguarding, and children and adolescent mental health service interface. There we go.
Good. And do you want to summarise the BAF, or are you all right with that? It's the final item on our agenda.
If you can see it, yeah.
I've got it here. Can you see it? I'll expand it for you.
So on our board assurance framework, for all the objectives that we set ourselves for the year, the number of greens has gone up by 1. However, we have ended up with some reds, which we didn't have, and I think they relate to money and learning from deaths, and because we haven't put the infrastructure in place yet, and we haven't yet managed to have the resource available to do a critical care outreach team.
But I think it's important to note that this is Q2, and actually you've already heard in the earlier part of the discussion that we're moving forward with some of these challenges, but this is the position as of the end of Q2.
In terms of the critical care outreach team, is that something that is, if you like, something that all trusts need to have, with all trusts that offer critical care?
I think we'd agree that it is, most trusts have critical care outreach team. In this organisation, I think we've provided care to our sickest patients via other teams. And actually we have done things in the last year that enhance that, in that we've now got an additional nurse practitioner on site out of hours who helps ensure that the sickest patients are seen quickly. So the critical care outreach team would be an additional layer of support for our teams. And I think, to be clear about the challenge, that the nursing staff that would be on the team are nursing staff that are trained and currently work within our critical care unit. So to be seconded into the outreach team, we need to have increased the establishment of nursing staff on critical care,
Yes.
and I think that's the challenge.
That is the challenge currently.
Presumably they're quite rare people,
They
critical
are.
care nurses.
Yeah, they are. They are special breed.
There's a long training programme,
Yes.
and then they're in demand when they're trained, so you can train your own, but it's quite likely they'll seek offers elsewhere. And that does apply to all intensive care units.
Right. So do we have a date when we'll have this up and running?
No, we don't have a date, but what we are looking, as Dan said, it is quite a long training program for critical care nurses, and we're looking to see if we can develop something in conjunction with, the universities to start supporting our own, to grow our own, as it were, to be able to deliver that level of care, so that we can release the critical care nurses.
Okay, thank you. Right. So I think that we're going to have a report back from the various execs and NEDs who are doing the 15 Steps Challenge, but that's not for 10-15 minutes, so I think we might as well move straight to some questions and points from you, if you'd like to.
Can I just following on from the nursing question? And obviously, one of the key things I'm going to be interested in is the proposals for the one acute centre instead of the two that we've got now. And what I keep trying to understand is, you've talked about critical care nurses and the registered nurses and then the healthcare assistants, that if you've got your most skilled nurses, presumably will be in the acute centre, and I'm just wondering if there would then be, with the wards that are left, that you say the hospital that will be left here, will be staffed by less skilled nurses, sort of overseen by a smaller number. I just wonder how it all plays out, instead of having them all in one place.
So I disagree. It works very differently, as in our more skilled nurses will need to be on the legacy sites or whatever we want to call them, because actually they'll need to work quite independently, and so therefore they will have to have the knowledge and skills to be able to work in that way. So actually we will have more skilled nurses, and that's why we're looking at developing, as it were, our own academy to train up those nurses, because they will have to do physical assessment. And currently we have our ED nurses do that, and some of our critical care nurses do that. We will need to have lots of those ANPs, advanced nurse practitioners, in all of the wards, because they will have to work a lot more independently,
So
nurse-led.
Who would be making those decisions? as
Which
it stands?
decision?
Well, the reason that you would need them to be able to take more responsibility, who takes that responsibility now?
So it's joint, and we have consultants currently, and in the new model we will still have some consultants. However, as I say, the nurses, and it is the right thing to do anyway for patients. Healthcare is changing, and a lot of the patients are becoming more acute, more dependent, and therefore we really need nurses to be upskilled. This isn't new. This is going on everywhere else. I think we're just catching up, but that's the plan, to upskill our nursing staff. So the registered and the unregistered. So we have the first batch of nursing associates, for instance, will be starting in January, or will go onto the register in January, and it's about re-looking at the workforce that we have from a nursing perspective. My view is that we need to upskill all of them, so that's the process that we've started.
Hello, Bob.
Good morning.
Morning.
This is my last day here. I've got fed up, right?
Okay.
You've changed the order in here, you've changed the numbers in here, and it makes it very difficult. A, I don't have a printed bit of paper, and B, I find it very difficult to go through all this when you're changing numbers, yeah? I've only got an amount of time available, yeah? You don't provide them with on the right you say 5 days before the meeting, that means they have to be on my desk for 9 o'clock on a Monday morning, not me ringing up on a Tuesday afternoon and saying, hey, what the hell goes on? I'm sorry, but it's very hard, yeah? Okay, I've said it, I'm finished, right? Because it's no good for me. I can't deal with all this, but I'm too old, right? But, okay, you spoke, I think it was, doesn't matter who spoke, about risk assessment VTE and risk assessment dementia. This has always been a bad spot, hasn't it? It's not, why can't we do better, is what I'm saying. Why isn't it better?
So Bob, I think you're absolutely right. What I would say actually is we used to deliver both of those. At times in the past, we've delivered against both of those indicators. And that's why we've gone back. If I take the dementia screening, if I go back and say, well, 3 years ago we delivered it, why did we deliver it? And the truth of the matter is we delivered it because our nursing teams were much more involved in helping facilitate the dementia screening assessment.
We know, don't
I
we?
know,
It's just
no. So we've gone
understand.
back. We are looking, and I assure you that not delivering this is not acceptable. And actually, what is very clear is that it has to be a responsibility that's shared between the different clinicians. So I think we are looking at different ways of doing this, which will make a big difference for dementia screening. And VTE assessment, what we have done, we've done a lot of unpicking in the last 2-3 months. And what's very clear actually is that the whiteboards that we've got on the wards are making a big difference in making sure the assessments are done in the complex medical patients. But the patients where it's not being done, as I think I may have said before, it's patients coming in for a more simple, straightforward elective procedure. And as many of those are seen preoperatively, that presents an opportunity and a time to actually undertake the assessment. So I really do share your frustration, and I really do anticipate that with changes in the process, we will begin to see an increase in both of those very important metrics.
Yeah, I mean, okay, but here okay, thank you. Numbers, there's 2 1-2s in here. One of those 1-2s used to be a 1-5. Is there an NHS format for doing these tables? Right, so I know what you've done. You've changed it to suit your presentation. But it would be nice to tell people up front that you've changed it to suit your presentation, instead of giving me the frustration of having to pull the last month, and I've been trying to sort it out. I can't sort it out. It's too difficult. Not too difficult. It's time consuming. Yes, and I wonder how many of your board members have actually looked at these sheets. Yeah. So how many people know there are 2 1-2s? Right, and it should have been a 1-5, or it was a 1-5 last month. By changing things on them, and I understand. Yeah, I understand now why you've done it, but it's not very satisfactory in the middle of a year to change things like this. Yeah, when you've got outsiders looking at it, you've got CQC looking at this, and they must be saying these people are nuts. Sorry. Thank you very much.
That's quite flattering to be called as nuts, I think. So we have changed the performance report a lot, and we continually change the performance report because the things that we need to measure change. And we
still got the same heading.
Yeah, so we've got the same headings, but
Down the side, you've still got the same headings down the side.
but it's an evolving, dynamic document that has to capture the things that we think are important about the running of our organisation, and there's no prescribed format from the centre about how to do it. It's what we think works for us, and sometimes we make mistakes in it. I get that, but overall, I think what we provide is a huge amount of information about how well the hospitals are performing on lots and lots of different dimensions, and the performance report is used in all the board subcommittees. It's also used in my team meeting, and I would say that every member of the board knows a lot about what's in this document because it's the basis of how we make lots and lots of decisions.
Bob, I would ask you to contrast format and indeed the content of the board report now to what it was, let's say, 5, 6 years ago, when it was just basically a dense lines of text.
Okay, I take that on board.
I think we feel that it has improved, that it gives us more information, gives more visibility, and the way it's designed means that things that we really want to focus on stand out and are brought to attention. So nothing is perfect, and Daniel's quite right, there is no, if you like, NHS-wide system. Maybe there should be, maybe they should mandate that every single trust reports in exactly the same way, and then you could do comparisons between trusts, but they don't. So this is the report that works for us, and we feel that it is actually a helpful document. And as Daniel says, it's not just the board uses this gets cascaded down all the way through the organisation.
Right, I think then people will find this very confusing to have the numbers changing, and I'm not going through the report, right, because I haven't gone all the way through it, and really, you won't take any notice what I'm saying. So, no, don't answer. I work very hard at this, but I've only got a limited number of hours. I might be retired, but I've got other things to do. And, last night I was working away at it, and I've used last month's report to compare against this month's report, and I just find it quite difficult. Yeah, without paper, well, on a computer, and I don't have the facilities you've got, and the public don't have the facilities you've got. And if you want the public to comment, they have to be able to look at the whole document, yeah? And it's very difficult without paper for an idiot like me.
Right. We'll take another couple of questions now, then we'll go on to the report back from the 15 steps.
Can you explain about what's going to happen with the birth centres if we get this new acute unit? Is there just going to be one birth centre in with the consultant-led, or there won't be something separate either side? Because I've had an urgent cesarean. I know how quickly these things, bad enough for me the idea of people travelling further for anything but having to move between.
Yeah, it's a really good question, and it's an issue that the maternity subgroup of Improving Healthcare Together debated and discussed at length, and there was a lot of discussion on this. Should the group propose a freestanding birth centre or only co-located? And I have to say that the consensus view from the clinicians involved, and that's both hospital and primary care clinicians, was to put forward a proposal for a co-located birth centre rather than standalone. But clearly that's an issue which I'm sure will be subject to further discussion if and when we progress through to consultation.
Sorry, I missed that. What centre?
So a birth centre, or a midwifery-led unit, would only be on the same hospital site as the unit that's got the 24/7 obstetric cover and labour ward. Whereas, in some hospitals you have a birth centre that exists without the labour ward and the consultant medical staff being on site.
Hi, Beth.
You mentioned NHS1 and NHSE. What does Epsom come under? Because we're not part of London.
They're both national bodies, Beth. They're England-wide bodies, NHSI, NHS Improvement, NHSE, E for England. So they're both England bodies. There is a London region. There is also a South region, which Epsom or Surrey comes under.
But what's
So
important?
Surrey Downs comes under
South.
West London?
South. NHS.
No, NHS South.
South.
Oh, okay.
So, but you will know that Epsom and St Helier is counted as a London-based trust. So currently, all our deficit sits in the London region. So, when I said in my little strategic bit that we're getting much closer to doing a place-based system, one for Sutton and one for Surrey Downs, we have to end that Epsom and St Helier is always counted in London, and we have to say that there is a London part of Epsom and St Helier for Sutton and a Surrey part, and an Epsom part is in Surrey, so that we can actually get a place-based budget that makes sense for the two places. because otherwise you end up with Sutton carrying a £35 million a year deficit and Epsom carrying nothing. So we're in the beginning of the negotiation with the regulators to say, don't split up Epsom and Helier structurally, because that's really important that we all keep together, but please can we have the money that is a Sutton bit of money and a Surrey bit of money, if that makes sense.
And can I also ask, is this the new cladding out here?
No, that's
Yeah.
the old.
Oh,
Well,
fine.
you can see the new, I showed you the back road behind you, but we can go show you. Just walk down the road 15 metres and you can see it.
Right. And then the final question is, people are being given notice to quit Rowan House where they live. What alternative accommodation is being made?
So we've got much better accommodation. So we have leased some properly constructed residential buildings in Epsom for people to live in, which are kind of like acceptable places to live as opposed to not acceptable accommodation.
Good. I think what we'll do now is we'll do the 15 steps report back, which will take about 15 minutes, and then we'll come back to questions for the final bit. So let's do that as everyone's now back. I think everyone's now back. No, Richard's back. But Lisa is back. And Lisa went to ITU.
Yes. Is it? Should I
Yeah,
come out
just
the
come
front
up here
then?
and, yeah, thanks.
Okay,
Lisa.
so, borrow that. I went up to ITU and I spoke with a large number of the nursing team who work up there and 2 of the doctors. It's nature of ITU, you can't actually talk to the patients really, but I did get an opportunity to speak to some of the relatives who are up there, so that was really good. So an overview from the staff was really positive. They were really positive about it being a great place to work and the fact that they loved working in ITU. And in fact, when I asked one of the nurses, so what makes it so good, she said, I've worked here 15 years. Do you really think I would work here if I didn't love it? So they were really positive. They felt the team worked really well together. They were very pleased in terms of the recruitment strategy which had been put in place. So I asked them about the numbers, and they said yes, they sometimes do struggle to fill shifts and they do have some bank staff, but they were very positive about the bank staff that go and join them, and they said the fact that we'd changed some of the rates of pay for the day shift workers had a positive impact, and they were pleased that the operational teams and the management had listened to their concerns and dealt with that. They said they had an incredibly supportive matron. She comes in on her days off to check on staffing and to check the staff are all right. And I asked, is that a regular occurrence and do we make her do it? And they said, absolutely, we don't make her do it, but she loves to come in and she does that on her day off. I asked about, do they know who to escalate to if they've got an issue, and do they find escalation easy to do? And they absolutely knew how to escalate. They sometimes felt that the escalation that they made, sometimes the response didn't come back as fast as they would like it to, but they definitely knew how to escalate. The main safety concern for their area, which I think is a really interesting one, is not the way in which they deliver their care. It's around the facility and the environment. They note that they are very excitedly waiting for a new ITU, but they found their environment very challenging in terms of safety. And I have to say, I was up there and it was well hot. So goodness only knows what it was like during the very hot days. And what they say to me is that the nurses particularly said to me, sometimes it can be very hot or it can be very cold. Trying to manage the temperature in between the two is very difficult for them. So their safety issue was really around the environment and the lift. And I went up there and guess what? The lift's out of order, as we know. So the lift literally to the theatres and right outside of their facility is out of order, which means we're having to transport patients quite a long way to the facility. One of the challenges and concerns that has been raised, and it is known, so I will be very careful how I feed this back because it is about confidentiality too, but I think it needs noting that they have recently had an extremely challenging and very difficult case to deal with. Pardon? Oh, okay. And they were very pleased to see that the organisation was responding, and they were pleased particularly that James Marsh, Dr. March, had taken such an interest and were very positive about that input. And that came from the doctors as well as the staff on the ground. So they were pleased, so that was worth feeding back. And of the medication storage and management, as you would expect, Chief Nurse, you'd be very pleased to know it was perfect. I could not find anything out of place. I did try really hard. Thank you.
Thanks very much, Lisa. That's very encouraging, I think. So let's ask James and Ian to come talk about Frank D's.
Right, so I'm going to lead and James is going to fill in the bits I've forgotten about. So Frank D's ward is actually signposted as surgical admissions unit still, but it's 4 days ago it became a medical short stay ward. So it's a component of the acute medical admissions unit. Positive things, staff...
Sorry, Ian, is that a temporary thing or a permanent thing? Yeah.
Yeah. Staff morale was good, so the nursing staff we spoke to there were pleased that they'd been given what was a better environment than they'd been in and seemed to enjoy working with the team there. And the medical staff seemed, morale seemed good. There were empty beds available, which is an almost unique feature in a hospital doing acute medical admissions like this. I was rather jealous and would like to take some back with me because it's and I think it's a marker that the patient flow for emergency admissions is something that Epsom St Helier is very good at, and so that the facilities were there. In terms of things that could have been better that we saw, clearly the physical space is the building that the wards are in, but there are very few beds that you can clearly see from the nursing stations. So it's not an ideal environment for acutely unwell patients, but it's the building, and there's nothing that can be done about that. And I think that the best use of the space had been made, but just an absolute constraint on that. The notice boards when we came in were a bit out of date, but you know, I suppose a mitigation is that the ward had just moved and they were just getting bedded in. There was some anxiety that there wouldn't be a full complement of trained nursing staff this afternoon, and James quizzed a little bit about escalation on that and got pretty much the right answers, that if the nursing staff in the ward were concerned about safety, they would do appropriate things and would make sure that that was covered. The resus trolley had been checked today and was up to date. The drug cupboard in the doctor's office was open, and the clinical room was available to public access if somebody wanted to so do. So overall, you know, with the problems on the ward, a team that seemed to be coping with having made their move.
Thanks, James.
Just a couple of things to add. So the nurse was concerned about the staffing levels for this afternoon, but as we came on the ward, she asked if if we wouldn't mind holding on for a moment because she was on the phone to the matron escalating, and she was keen to continue to escalate if she didn't feel she had safe staffing levels, up to and including a point where she may potentially refuse to accept additional patients onto the ward if she didn't feel it was safe. Dan, I don't know what you've done, but there's an amazing number of empty beds on the ward. There was it felt like it was still a ward in transition. On the corridor, there's a bit of clutter, and I think there's unnecessary clutter in the corridor. There's bits of shelving, there's an old table, so I don't know why they're still in the corridor, and it doesn't give the sense of a a smoothly running, effective clinical area as you approach the ward. The staff seemed very cheerful. I spoke to a couple of the patients. They were very appreciative of the care they had. They felt that they understood what their plan was for getting home. One of the senior doctors who was doing her consultant-led ward round said the therapists felt that it was a much better environment compared with the ward they just moved from, because it was easier for the therapists. There was a bit more space for them to complete their therapies.
Thanks very much, James. I think that's encouraging. It's particularly encouraging in a way that the nurses, you know, the person in charge of the ward is noticing or predicting that there will be a possible staff issue and is doing something about it. I don't know whether that comes up to you.
And can I say that? Yeah, I have got that
Right.
already, and we've done something about it. So
That's good.
yes.
If I may, it's probably worth adding as well that is firmly a ward in transition. We made the change on Monday. At the time, it stopped being a surgical admissions unit and became a medical short stay, but we've had a high number of orthopaedic admissions, and we're still managing those out of the ward. So there's still a slight mix of patients that we're working out. It's very much the case that it's in transition, but it's going to become an old people short stay unit. So it's going to be designed for people at about the 3 or 4 day length of stay coming off the acute medical units. They shouldn't be the most acutely unwell patients going onto that ward. That's the design of it.
And just one other thing, there was a healthcare assistant who was doing a bank shift. She's just approaching her 60th birthday, and she had the enthusiasm of a 30-year-old. And she just said she loved coming to work every day, and quite inspirational.
Excellent. Thanks very much, James. Let's ask Debbie and Peter to come and talk about their visit to Richard Bright.
Thank you. So we went to Richard Bright. We also went to B6, given we made the time to make sure we went to more places than just the one. So for Richard Bright, which is a renal ward, the infrastructure is quite very clear from the outset when you walk down the wing that there isn't room for all of the equipment that's necessary to provide appropriate care, and that's sort of the dominant thing that strikes you when you walk in. But the staff we spoke to and the patients we spoke to spoke of good care, being part of a team, good communication. They had some staffing issues that day, but they were working that through. And we spoke to one particular nurse who perhaps Debbie might just sort of say a little bit about.
Yes, we met a really lovely Band 5 nurse who actually started in the organisation as a healthcare assistant. And really it just showed the journey of development that she had, supported by the organisation. She was sponsored to do her nurse training here, which we did, and came back to work here. And it was just a wonderful, inspiring story, and I think it's something that we really should promote, demonstrating the development opportunities we can provide staff in the organisation. It was really inspiring, and she loves working in the trust.
So then we went to B6, which is our step closer to home ward currently. We spoke to the nurse consultant and some of the team. They feel like an organisation, a ward in transition as well, as they're moving towards Sutton Health and Care, and seeing the very positive things that can come out of much closer working together. But in that transition, there are staffing issues that clearly need to be addressed. With some of those including in leadership positions. So there are a number of challenges there. The patients I spoke to were all happy. They were sitting out, but not all of them were dressed, getting ready for that being ready for home. So there's quite a lot. There's one of the staff members I spoke to really echoed the many of the themes that are coming through are your voice, your values around not necessarily sufficient communication and teamwork, and about how we work effectively together to kind of give the best to our patients. So there's clearly you're reinforcing the things that we are identifying that need addressing are very much central to certainly that member of staff's sort of journey and perspective on what it is like to work here.
I spoke to a few patients, and I think their main concern was around the length of stay and really wanting to go home, and it's that was a key focus for them really.
Thanks very much. So finally, Richard and Trevor, who went to C5 escalation.
And.
You did more than that.
Okay, so first of all, Richard and I went to C5, which is an escalation ward. As Director of State Facility, I have to say I was extremely disappointed when we walked onto the ward. It is, in effect, the worst environment for our patients at St Helier, and that's why it's an escalation ward. And I think it's disappointing that we've opened it up as escalation and we haven't used an opportunity to actually do a little bit of refresh, redecoration, and the disappointing where we've had some notice board with double-sided sticky tape, which is just the notice being pulled off, but we haven't actually cleaned the sticky tape. It is a poor environment, bed spacing, very cluttered, and I think there's just some quick wins that we could have done before we've opened up for escalation, which is disappointing. I think certainly something we need to try and pick up if we've got some capacity at the moment, how we could get in there and do some quick work. As a whole, we spoke to the sister. There were some free beds. There's 6 patients on the ward. Staffing levels were established and were correct and were fully staffed. I think they had mentioned that there's sometimes a few challenges, but they do share that staffing with B5 and work closely together, so that worked well. I think there was another challenge that I think they said is that they've been open for some time now, but they didn't feel that they were fully equipped as a ward. So they mentioned things like that they having to share a bladder scanner that is actually in effect delaying diagnostics and patients' discharge. ECG, they didn't have access to a weighing scales, a hoist, although we did actually find a hoist which seemed to be operationally in use, so I think perhaps a little bit of that. We did speak to the ward sister about how that escalated, and they did mention that it has escalated to the matron, but I'm not sure what's happened because some of this equipment is not expensive, and I can't see any reason why we can't just get that resolved, and certainly something I'm happy to take forward in addressing. We spoke to a couple of patients, which, considering the environment that I was very disappointed in and not happy with, they seemed quite upbeat with the environment, probably a little bit confused with patients, but as a whole they were happy with the food that were provided. They had plenty of food, and it was regular, on time, and of their choice. They were generally happy with the care. I think the only other comment that they mentioned was about actually it'd be more helpful if more people introduced themselves. So thing as part of our badges and actually hello, my name is, they felt actually that wasn't consistent. I think that was on that ward.
Yeah, I mean, look, I just echo what Trevor was saying. I think as an institution we should be embarrassed about C5, quite frankly. And it's not something that I would be proud to show anybody around. It's as simple as that. And whilst I think the nurse that was on duty was doing an efficient job, there was almost a sort of an air of resignation around how she discussed or relayed the challenges that she faces. So I thought it was really disappointing.
Yeah, that's very interesting. That's somewhat of a contrast to some of the other reports we've had. And do you feel that it sort of has slipped through the cracks of our improvement programme?
So I think we've had it on our site for some time, and that's why it's an escalation. It's not a substantive ward. But I think that we've missed an opportunity this summer in trying to address even just doing some basic improvement and maintenance works. I mean, we came across a shower room where the shower's being out of action. It's clearly being out of action for months and months. The signage was really poor, and no one looked like they'd taken responsibility. It felt like there's a lack of ownership about, actually, we know the ward is in a bad condition, it's escalation, let's not worry about it. And I think there's
clearly an action plan over the next week that we can address some immediate concerns. And I think we have to try and look at, is there something now we've got a bit of capacity at the moment, a short-term bit of work about just refreshing and putting some TLC into that ward.
Good. I think you should absolutely take that as a priority, Trevor.
I think just on a contrast, that was quite depressing for me, and I just wanted to show Richard as well, in terms of when we do reinvest the money onto our walls and actually sort of adapt and refurbish them. We went onto the new surgical assessment unit and the extension to Maymore ward, and just the vast difference. I just wanted to show Richard actually what we are spending some of our capital money on, and what actually a difference it does make in terms of the space, the environment, the clutter around the walls, etc. I don't know if Richard wants to.
And it's just such a huge contrast, and there we should be truly proud of what we've achieved. The other observation I would make is that the impact it appears, at least on the face of it, to have on staff morale. People were genuinely proud. There was sort of ownership of the environment, and there was just a more upbeat sense of morale on the ward. So it was like night and day.
Okay. Well, I think that's a clear action point to take away in terms of Steve Live. Maybe we can move people out temporarily while we fix some things, at least do some short-term fixing.
Yeah, I think so.
All right, thank you very much.
Thank you.
Thanks, everyone. Good. Right, we've got a few more minutes left, so if there's any other questions. Sandra?
A couple of things really. One's well, they're both for information. Can you tell me what the number of beds you've got between the two hospitals now, and what catchment area you're covering? And then, what number of beds, and I'm not asking acute this time, I'm asking beds in total, will you have in each of your three scenarios, and what the catchment areas for each of those would be, if things went the way you would like them to go?
So the answer to the first question is, it's somewhere between 1,000 and 1,025. Depending on how many patients have beds in currently, and you've just heard we've got some beds that don't have patients in.
Aren't you supposed to have 5 or 10% that don't have patients in?
Well, the planning thing would say you should have 15% of patients that don't have beds in to make it perfect. But I've never, in my entire career of being an NHS manager, I've never been in a hospital that's ever achieved that. So between 1,000 and 1,025 now. The information that was presented at the workshop this week said that the bed model for the future would be between 1,061 and 1,091. So that's more beds.
Sorry, could you repeat that? 1,000 what?
1,061 to 1,091, depending on the option. The catchment size for the trust is about, for the district hospital services, so being for the emergency service that Epsom and St Helier offers, so the two A&Es, is 490 something thousand, depending on which specific. So say 5, and that's broadly 197,000 for Epsom and 300 and a little bit at St Helier.
But how about for the hospitals then?
Well, that's if then you add it together. That's the catchment for Epsom and St Helier.
Not just the A&E. I thought it was
So,
just the A&E.
well, that's A&E. So then you've got different services that have different catchments. So if you say the orthopaedic centre, so that's the whole of South West London and Surrey Downs. So that's like almost 1.5 million people. So the team that you've heard about went to Richard Bright. Well, that's one of the renal wards. So that's a catchment of 2 million people. So, because that's a regional service. So the different services have different catchments.
Did you not tell us back in 2015 that the catchment area for Epsom and St Helier was 500,000?
Yeah, I'm telling you,
So it's not grown?
it hasn't grown. Well, not materially, not in the last couple of years, no.
In the last 5 years it's not grown?
It's grown a little bit by whatever the population growth has been, but it's it's not huge. So,
Actually, in your annual report, it 500,000 back in 2007.
so broadly, the trust catchment has remained the same. For we haven't increased our catchment, we haven't decreased our catchment. We are the district.
The population's been stable for the last.
So the population clearly has grown a little bit because there's been population growth in the area we serve, but it has not been material, and the figures I've given you are based on the census data. You see, so the census gets refreshed every decade. So in the ballpark, Epsom and Helier has a catchment for its A&E service of just under 500,000 people, which is what it has been for quite a long time.
Okay, and the question then, in your plans, in each of the three scenarios, what would the bed numbers be in each of those scenarios, and what would the catchment area be in each of those scenarios?
So depending on where the acute hospital is sited, the catchment area changes.
Yes.
And what the information that was presented to the people this week showed was, when the catchment area changes, where would people go to access the acute emergency services, so that the aggregate availability of acute services was the same in all of the options. But broadly, what they were shown was that in the Epsom site, if Epsom was the acute site, then that would be the smallest of the three, because more people would end up at a different hospital for the acute services, because the population density is higher at this end of the patch.
Okay, so in Epsom, how many beds would you have?
So we're going into levels of detail that are not actually yet finalised, which is why I'm.
Well, you
which
put
is
them in your
yeah. So we did, yes, as a provider, and you know.
So that's what I'm asking you.
So, yeah, but now the commissioners are refreshing the whole process, which is what they are doing, and they haven't got to the end point yet. So they presented sufficient information earlier in the week to enable people to assess this was about the impact on other providers question, and the biggest impact on other providers is if the acute site is at Epsom, because more people would go to another hospital for their acute services if the site was there. And then
So how many beds would you have in this refresh? How many beds would you have at the smallest one, you say, Epsom?
So my answer to the question is the same one I just gave you a minute ago, which is the commissioners haven't yet finished the piece of work. So that data yet isn't completely available. They've done the assessment of the impact on other providers in terms of scale of flow, and that's what they were using.
But they can't do that until they've got numbers, surely.
So they gave ranges and indications at the workshop.
So could you share those with us?
I can't, no. So you'll have to ask the CCGs whether they would like to.
Well, what was in your plan then?
So you know what was in our plan, because we've published our plan.
Well, to be quite frank, it's very difficult to interpolate your plan, because things don't seem to be based on the same criteria in each case when you give numbers, which is why I'm asking you now, in your plan, how many beds did you have in each of the three scenarios, and what was the catchment area?
But as you've just correctly identified, the bed numbers have changed. So when we presented our plan as a trust, we didn't have more beds in the model than we started with. Now the commissioners have redone the plan. What they have concluded, we do need more beds than we currently have. Well, the implication of that is the bed numbers that we put in our model are now going to have changed. So there's not much point me telling you all the bed numbers from the piece of work from the strategic outline case.
So when can we see this new work?
So when the commissioners have finished it and put it in the public domain. So I think we're heading for the commissioners being able to do that in about February 2019.
So how can you have had these decisive or these fact-finding or decision-making or adding to the decision-making process engagement meetings when you're going to be working on an entirely different scenario?
Because
What value is the research you've done so far
so-
if you're changing the baseline?
So you keep saying it's us. Right? It's not us. It is the commissioner's work. And if you looked at who was in the room doing the assessment, there was no one from Epsoms and Helier in the room doing the assessment, because the impact of what the commissioner's decision is on Epsoms and Helier. So the questions you're asking are actually much best answered by the CCGs who are running the process. And nothing they did this week was decision making. It was all getting input to enable the CCGs to be able to make some decisions in the future. But they didn't make any decisions this week.
But they were assessing things, and it appears they were assessing things without any facts and figures to assess.
So
How can you, for instance, decide what impact having one centre instead of two could possibly have if you don't know how many beds you would have in that one as compared to the two we've got now, or what sort of number of people those beds would be expected to cover? Pretty fundamental, I would have thought.
So lots of information was presented to the people in the room, but the question you are asking is not a question Epsoms and Helier can answer, because you're asking questions that the CCG, who are running the process, should answer for you.
Okay. Can you just explain something to me that's been puzzling me for a long time? You've often talked about the layout of wards, how the Nightingale model doesn't work, how the model you've got here, which isn't usually the Nightingale model, doesn't work. And someone said earlier that all the beds aren't visible from the nursing station, and that's not a good thing, but there's nothing we can do about it. Can you explain to me, this is a genuine seeking for information, can you explain to me how that would be improved in a reconfiguration where the nursing station's in the middle and half of your patients are in private rooms? How does that improve the visibility of patients from the nursing station?
So in the strategic outline case document that we produced, we showed the public, what a modern purpose-designed ward looks like.
Yes.
And if you look at the picture that we showed you, you'll be able to see how it is that if you design a ward.
There are several rooms that you can't actually see from the nursing station.
So you'll also see in that thing that there were some sub-nursing bases to enable that to be possible. But what you don't have in a modern design ward is what St Helier has got, which is, so you're looking at it now, right? So in the bit across, there are beds. In the two wings, there are beds. And you end up with wards that are completely disjointed from each other because all the ancillary accommodation is in the right angle, in the corner. So you end up with a 25 or 6 bedded ward actually being 2 13-bedded wards.
No, but that's a different,
No.
different problem. But you were saying in some wards now, all the beds aren't visible from the nursing station, and I can see that's a major thing and some advantage to have, especially with very sick people. How is that improved by having private rooms?
So they're not private rooms.
Or
They're,
separate rooms?
they're single rooms.
How are they visible
But-
to the nursing station?
Arlene, do you want to try?
So I think the main thing is that nurses' stations are not for nurses to sit down or when they're on shift. So actually we should be moving, even with the environment that we have, to models where nurses are just out and about, which is why we are increasing the nursing leadership to give one person overview of all of it, and so that the junior nurses and everybody else can be around. So in any new reconfigurations, nurses, so I wouldn't even call them nurses stations, there will be bases where people can sit to write, but not notes, because actually if you're writing nursing notes, you should sit with the patients. So it is really just an admin station because the staff will be out and about. I have worked so one of my elderly care wards in another organization was all single rooms. And we had bases where we did admin, and it was staffed to ensure that we could check on every single patient more than once in an hour. So it is possible to do. It's about changing how we work generally, and the idea is that we should be out there with patients as nurses all the time, and then we have all of our therapy staff and whatever coming in. Those stations are really just about a point where people can, if they need to, sit down to make notes of telephone calls or whatever. But the plan would be that staff are out with the patients.
So that the staff, so that all patients aren't visible from any one place.
So the patients, don't need, the patients that need to be visible all the time will be placed where they can be seen all the time. Not all patients need to be seen every single minute of the day, and the nurses moving in between wards will ensure that patients are seen more than once an hour.
Sandra, I think what we should do is we should take you to C5 and the new surgical ward, right? And you can decide which ward you'd like to be a patient on if you were sick, because the new surgical ward, which we've managed to build not in the U-bends of all of these blocks, but actually we've built on the first floor on a huge area, which is a big flat first floor area, is a completely different environment to be cared for that we would like to do for all the patients. But you can't do it when nearly all your ward block is this thing that you're currently looking at. So then you will get an answer to your question that you'll be able to visualize. So I think we should arrange a time to do that for you.
It's just that you seem to be basing your criticism on the fact that you can't see all the patients, and what you want to move towards is somewhere where you can't see all the patients.
So that is one small aspect of the things that are not right about the nursing, or about the wards in Epsom and Helier, which we have said many times. So remember that other things are about the bed spacing, the lack of single rooms, the infection control risks, the really hard thing to clean. All of those things are true.
Well, if one of the major problems, is bed spacing, does it make sense to want to flog off part of the land that you already own and have less of it? And if it's about bed spacing, you could move people apart. If you didn't import things like WH Smiths and the other new things that you're bringing here that have got nothing to do with looking after people, you'd have more space to space the bed, surely.
So I think we would say that having amenities like Smiths and Marks and Spencers is everything to do with looking after people, because they are massively valued by our staff, for one. And the whole point about building a brand new block on one of the three sites is to create 400 or 500 bed spaces that are fit for purpose, that comply with all the health building notes and are great. And then that enables you to go back to the existing buildings and take out a whole heap of the beds so you can create the right bed spacing in the existing buildings. That's the plan.
Why are you selling land? Because you're denying yourself the opportunity to do that now or at any time in the future. Once that land's gone, it's gone forever.
Yes, which is why in each of the options that the CCG are considering, we have safeguarded the space that you would need to build the blocks that would have the new beds in it. And if you and you also know that the trust gave a commitment a couple of board meetings ago that we weren't going to complete the transaction for the surplus land at Epsom until we had had confirmation from a bunch of independent consultants who the CCGs had appointed to demonstrate that you could build the building at Epsom if Epsom was the chosen site, even if we have sold the land. And that commitment remains true.
So you've committed not to sell the land at Epsom?
Until we have the confirmation from an independent group of engineering consultants that you can build the acute site at Epsom if that is the chosen site.
And yet you've used the expected money from that sale. At last month's board meeting you said, yes, you admitted you'd used all of that money to pay for this year's running costs and balance your budget. Only this week, at another meeting, you said, oh, whoopsie, we've got double that, we're going to use that to refurbish Epsom.
So that's
all this based on a sale that's not yet going ahead.
So none of that is true, Sandra, as well you know.
What?
So we have been absolutely consistent that the money that we're getting for land sales goes to contribute to the paying off our in-year deficit. Yeah. And then we get the same money back again to invest as capital to sort out the existing buildings. We have.
Daniel, you didn't say that last month.
I have said that. I have said that every month for about the last 2 years in many, many, many settings. And I've got. There's Rakesh, our CFO, sitting in the audience. That is true, isn't it? Yes, he's nodding his head. There you go.
I'll look back at the film, Daniel, because my memory is that you were challenged about having used the money you were getting for that sales just to balance the books, and that decision was questioned because it didn't seem like good use of selling a fifth of the land at Epsom just to make your budget meet this year. And to my recollection at least, you never said, oh yeah, but we've also got double that to spend at Epsom. But I'll check back at the film.
Right, time is pressing on, so let's just take these two.
Just a really simple question.
Yeah.
In the report back, you mentioned that the shower had not been working for several months. How that's a failure of a system, surely. How do you take a report who tells you? How does it get fed up the line? Why did you not know that? Why do you spend over 2 million with consultants, as is in your annual report, to develop plans to do whatever, and not fix a shower and take double-sided tape off a wall? As a member of the public, I'm shocked.
So you may have noticed, Trevor and I, this is probably a double-sided response, and I suspect Ollie may want to come and talk. There's two sides. So you may have noticed Trevor and I having a quite cross conversation, which asked exactly the same question. So yes, we conduct walkabouts. We don't go into every single area, and we do walkabouts. We are reliant to a certain extent on our line managers, and I mean from top to bottom, being able to tell us that. So normally we would hear about this because people are banging on mine and Trevor's door saying, my shower hasn't been fixed for 2 weeks and I want to know why. And then we've got an ability to understand it. The question I have just posed is whether we can get C5 closed the next couple of weeks, given our available capacity, to see whether we can do some of those short-term works. And I will be going round there this afternoon with Trevor to go and have a nose. So I absolutely agree with you.
Well, thank you. It's just, there was a front page story yesterday about it was about the workforce, and it described bullying and treatment within the hospital. I acknowledge that some of that was from the public, and I hope that's not a big problem in the hospital. But if it's also within the workforce, I just wonder what the reporting lines are, and if people feel able to say it's not working, and if they are confident that it will be dealt with.
So as I say, I'm extremely disappointed and embarrassed about that condition of that ward. I think, as far as I'm concerned, and Arlene, I'm sure will support me, it's a ward manager responsibility to escalate and chase and address that issue. Equally, they may have done that, and there may be an issue within the project maintenance department, and I need to find out and investigate that. There's no excuse, but I think there's certainly something around behaviours of if we give staff and patients the right environment, a nice environment, you get a very different response and ownership, whereas C5, I think there's a clear issue of, well, it's C5, it's in a state, we're not really looking at the detail, and I think there's something that Arlene and me need to do about actually, and Dan, all three of us, about actually, one, let's bring it up to best we can, but also about some culture change of actually taking some care responsibility in that area. So I totally accept it's a failing and we need to address it.
It's just a suggestion on this C5. Really, it's clear that the system for checking these things is not right. You need to do these 15 steps more often, and you need to visit more places. Simple as.
I think that's right.
Yeah.
I mean, I'm not trying to be defensive here, honestly, because I think
because it's just
really,
showing up a problem.
Yeah, it's absolutely, and that is the point.
If you can't trust your line managers to do it, you've got to go out and do it yourself.
And that is the point of why we do these visits.
So
obviously,
what's your plan to change it?
We do a huge number of visits, both in this setting, but also all the time when we're not at board meetings.
Trevor's just said there are places they don't go to, they trust their managers to deal with. That's got to stop.
It's a huge operation. We have to trust and empower our managers to feel free to speak up if they've got a problem. I would say, hundreds of times that works. And we are, aren't we? We are, I wouldn't say inundated, but we are regularly informed of issues, ranging from, showers to light bulbs to all sorts of things. So the system is there, and the system generally works. But obviously, in this case, the system hasn't worked.
Yeah, I remember in the Friends shop a few months ago, they'd been having problems with their heating. It was blasting out and they didn't want it, and I had to go and find Trevor and tell him because the system hadn't because they hadn't got any response. So I mean, there's clearly lines of communication problems going on, and it's been much worse in C5.
I mean, there's no excuse, but I have to say that the maintenance department are quite stretched at the moment. We're having significant issues around breakdown and failures of heating systems, lifts and stuff, etc. And it's a constant challenge. They are having to prioritise, but it's still acceptable. And I think you're right. We need to make sure that everyone's very clear on the reporting procedure and how to escalate if things aren't resolved in a timely manner.
And just sorry, that's one last thing is to say that where we visit as part of the 15 steps is decided by me, right? And in terms of escalation and the wards that I invite our execs and non-execs to go to are wards that I think that we should all see. And so we have had a discussion as well about improving or increasing the number of visits to some of the areas, especially our escalation areas, because we recognize that those are vulnerable areas, and that's something that we've already agreed to do. And so this visit, I mean, the good thing is when I go, I look at nursing and care of patients and pick any issues up around that. Trevor will always see all of the environmental stuff, and so it's about using different eyes, and that's what we are doing.
And we will report back at the next board as to what's happened about C5, and I very much hope and I very much trust that we'll be able to report back the problems that have been resolved. So we can undertake to make a report back, because you're quite right.
Mr. Chairman, this is
I'd
for
like
Arlene.
to start off with thanking you for your very full and fulsome explanations, and you have gone into it very well, I think, under adverse circumstances. And what is going on, I think it's very good that we hear bad things as well as the good, which you are trying to tackle. You know it's there, it's going to be tackled. My other question is really, it goes way back, and it's on just the area. I understood from some years ago that we had, that this site had part leasehold, one long leasehold and one short leasehold, and how's that impinged on the plans, and what is happening about those leaseholds? I think one's long from the council and one is short of the lease, and I believe the same is within Epsom to some extent. Part of that is property area is because when the hospitals were formed, they had a certain area, but as they've expanded, they had to take various land leases. So I don't know what is the situation in that now.
So, shall I pick that up? So, St Helier has a 999 year lease with the London Borough of Sutton. So it's a long-term lease. Under all the options going forward, we'll continue to provide healthcare services at St Helier. So we don't envisage that changing in any form. No restriction. There's a section of the car park that's on a shorter term lease, and that currently runs out in 2025. If my memory serves me correct, I will need to check that. And closer to that stage, we'll discuss with the London Borough of Sutton options for extending or what our requirements are for that going forward. At Epsom Hospital, we predominantly own the freehold for the estate, and again we continue to provide that. There's a couple of areas that we have a lease, a long 999-year lease with the Denbies Trust for Denbies Wing, and we'll continue to provide services and all the options. We'll continue to provide services from that facility, and we also have a residential accommodation block which is under the St Kilda Trust, which is out of its existing lease, and we're currently negotiating a new 15-year lease agreement with St Kilda Trust for that staff accommodation.
So it's going to
continue.
Yes, out of curiosity, how would it hinge on your future planning? Should these leases?
So I think all those buildings are essential for our, whatever option we go forward are essential. We want to maintain them, and I think all those partners are with us and supportive of continuing us using those buildings.
Good. Thank you.
Thanks, Barbara. Thanks for coming. I'm pleased you're here.
Just for Arlene, about notes done at the bedside. Everything is now done on computer. So as the trust has enough computer to go around for nurses to take the notes at the patient bedside.
So that will be included in any future planning that happens. Of course, we need to have the technology to make it work, but we need to recognise that that's what we need to have for patients to be safe. So it needs to be prioritised.
Thanks very much, everybody. We'll
So
see you
can I
next
just
time.
say, I think Best deserves a word, or I should say, because I'm going, she's under enormous pressure, not just by the hospital, but by her circumstances at home. And she's generated, how much, 5 million, did you say? 5 million over the years she's been working for this Epsom Medical Equipment Trust. And to put her under the pressure you're putting her under is unfair. Yeah, she's done an enormous amount of work, not just as far as the Epsom Medical Equipment Fund is concerned, but she's a separate pair of eyes which you might not like, but they're very useful to you. Yeah, she sees an awful lot of things that go on that she can help get put right. Yes, and just be a little bit considerate, please. And I know it's got nothing to do with me, but it is. She has done an enormous amount of work for the hospital, for Epsom Hospital, yeah? And she deserves at least reasonable consideration.
Well, yes.
No, I need to say it in public, don't I? I'm sorry, but I don't need to put it in writing. It's in public. Thank you.
Thank you.
And you won't see me anymore.
I
will see Daniel at Reigate Grammar dues.
I hope we will see you again, but I sort of think we will.
You sort of, no.
You said it before.
Look, I might have done. Sandra, she's in business with her husband doing this, right?
Not business. Not
no,
business.
no, you know what I mean. My wife, she is disconnected, and I'm nearly divorced sometimes.
If this really is the last time we see you, Bob, we will miss you a great deal. Yeah.
Well, I don't know. No. You might see me once. But you don't know where or when.
So we will definitely see you all next time, December the 14th. Thanks very much.